Thank you. I'm very honored that to be asked to talk on, I think, what everybody knows is a Cincinnati thing, and hopefully at the end of this time we'll have been able to impart a little pearls of wisdom. And this is interactive and probably easiest to save questions to the end, but please, I hope I generate some questions. HLH, or Hemophagocytic Lymphoistiocytosis, say that 3 times really fast. Hopefully we'll discuss the etiology, we'll discuss some of the common signs and symptoms, and discuss the management and treatment options for HLH patients. So what is HLH? It's uncontrolled systemic inflammation driven by lymphocytes that activate macrophages. It was first recognized as a sporadic or familial syndrome probably in the 1930s and 50s, numerous descriptions in the literature. In the 1970s, it became increasingly well recognized, and it was thought there was two forms of familial and a sporadic or secondary that was in the context of viral infections or malignancy. Late 70s, early 80s, the term hemophagocytic lymphohistiocytosis was coined, and there was also tried to make some international definitions. This led to a clinical trial, HLH 94, which was eventually followed by HLH 2004, which has come up with an international consensus treatment. And in 1999, the first gene defects in a perforin gene were described, which was the first biologic basis for HLH. Well, so when should you think of HLH? You want to think of HLH from a prolonged inflammatory state, prolonged fever, liver inflammation, elevated AST, ALT, elevated LDH, unexplained coagulopathy, especially hypofibrinogenemia, unexplained cytopenias, high ferritin, the absence of leukemia or lymphoma, and a sick patient of any age who you can't explain why they're sick. You may want to think, could this patient have HLH? Other clues: family history, unexplained death in childhood. We're now increasingly recognized that HLH is involved in unexplained hepatitis or non-viral or non-A, non-B, non-C hepatitis. There also now appears to be a subset of these kids that are with a genetic form that are predisposed to inflammatory bowel disease that typically shows up in the infant and toddler ages. And again, the unexplained child who continues to get worse despite any clear prodrome or clear infection, you may want to think of HLH. So these are now the diagnostic criteria that were used in the 2004 international trial. If you're lucky enough to have a known genetic diagnosis, and this was a list of current genetic defects, which has essentially doubled to about 15 to 18, and we're adding new genetic causes almost on a every 6-month basis. But the clinical ones that you'll face more in your general pediatric population are unexplained fever, splenomegaly, cytopenias, with 2 out of 3 of the lineages affected, with a hemoglobin less than 9, platelets less than 100,000, and an ANC less than 1,000. And as an inflammatory state, hypertriglyceridemia and or hypofibrinogenemia. Definition of a pathologic process with hemophagocytosis is always ideal. Bone marrow is the easiest to biopsy, though actually is one of the more difficult to prove hemophagocytosis. Spleen or liver biopsies are actually much more rich, but in general we shy away from doing those for the most part. It was believed that lower absent NK cell activity is a reasonable marker of HLH, though this is becoming increasingly questioned as we see lots of patients with no NK cell function who are not sick, so it's not clear if this is primary or secondary. Ferritins greater than 500 are a very useful screening tool and can be done anywhere. And the sine qua non of a hyperinflammatory T-cell-based problem is activation of the IL-2 receptor or soluble CD25, which when that's elevated, that shows hyperactivation of the T-cell phenotype. So we're going to briefly discuss 3 kind of common presentations. So you have a 3-month-old who develops persistent fever with profound cytopenias, hepatosplenomegaly and adenopathy, does have a positive PCR for parainfluenza, but continues to worsen despite the typical parainfluenza. You suspect HLH. This patient is screened and has perforin expression in its NK and T cells and has a soluble IL-2 receptor 10 times the upper limit of normal. This patient has the most classic North American allele, a perforin defect in the 50del-T mutation, and this is a significant mutation that makes their extremely predisposed to developing HLH with any insult, and these patients typically present in the first year of life and often die quickly if it's not recognized. A little more common and a little more difficult to diagnose is a 2-year-old who has a month-long intermittent fevers, develops cytopenias, also has hepatosplenomegaly and a rash, does not have any identified viral triggers. On screening, it does have an abnormal CD107A mobilization, we'll talk about shortly. Soluble IL-2 is elevated, but not as striking as the previous patient. Also has a history of benign cytopenias and recurrent fevers associated with mild viral infections. On genetic analysis, this person has a MUNC 13.4 mutation that turns out to be a heterozygote and has one gene that's a null mutation and one that's a hypomorphic, so still retains some ability to control their immune system, which is why they don't present until they're 2, but will continually reoccur with the same symptoms unless corrected. So the differential diagnosis that we consider in patients with HLH is this due to an infection. HLH is a great mimicker, so it mimics infection or may be caused by an infection. Some of the typical ones we see are after EBV, CMV, or adenovirus, but almost any of your viral or other, such as Ehrlichia, Bartonella, Brucella, can all cause HLH or lead to the development of HLH after your viral infection. You can see the development of HLH with your lymphoma, leukemia, or germ cells either at diagnosis or actually during your leukemia or lymphoma therapy. It also is a not uncommon complication in rheumatologic patients, especially those with the systemic onset juvenile arthritis, and this is called macrophage activation syndrome classically, but now it's becoming clear there's probably immense overlap between macrophage activation syndrome and HLH and often share many of the same genetic underpinnings. You can see it with Kawasaki's or severe drug reactions. In the young infants, especially those that have immune deficiencies, you may see it with patients with SCID who get viral infections, others such as Omen syndrome or DeGeorge syndrome. It appears to be a common presentation in adults in association with the malignancies, especially some of the slower growing malignancies, and we have had patients in our institution in their 70s and 80s come for evaluation of possible HLH. So classically the thought was there were 2 varieties of HLH, primary HLH, which was most common in infants. It was recurrent. It was thought that this had an NK cell defect. And then there was the secondary HLH, viral-associated HLH, macrophage activation syndrome. Classically, it was thought this was in older children. There was usually a trigger. You could treat them. They didn't have to have definitive immune correction with a bone marrow transplant, and these patients typically did not have an NK cell defect. And that was the paradigm when I was in training in the 1990s. We had primary and secondary HLH, which has been now updated probably to a continuum, which is a much better explanation, where we have patients who clearly have genetic defects, the familial HLH perforin mutations, others X-linked lymphoproliferative, Chediak-Higashi. There probably is a secondary HLH or virus associated, and these patients have a polygenic. They may be a heterozygote, or we just don't know yet. Macrophage activation in the rheumatologic kids, probably those kids that get macrophage activation also have a genetic underpinning, but we're still trying to define that. And then there's the normal who are unaffected. So somewhere in here, This side is patients who are definitively at this time need correction because they're recurrence risk. And it's these large group of patients in the middle that we're continuing to struggle to define what is the optimal therapy for them. So we get a lot of consults from the ICU, and the question is, could this extremely ill patient have HLH? And as a recent article in the Pediatric Critical Care journals by Dr. Castillo and company said that secondary HLH and severe sepsis and SEERS and multi-organ dysfunction really have such common intermediate phenotypes that it's difficult to separate any one individual in the context of an acute clinical. Because HLH is a syndrome of excessive immune activation, you have to have a high degree of suspicion, and there will be very significant overlap with patients who are sick with just sepsis, gram-negative sepsis, or even just severe viral syndromes. So how do we deal with this, or how should you deal with it? You want to maintain a high suspicion for HLH, screen early and often. Ferritin is a great screen and available at every institution. Soluble CD25 testing is now available through many labs, including our own. Consider early confirmatory specific immune testing, screening for the genetic defects, as well as consider biopsy. And continue that your first screen may not come and meet the definition of HLH, but consider that it may be an evolving diagnosis, and you may have to continue to rescreen and look. And the most important, the most difficult is in patients who you think have HLH, the treatment, as we'll discuss, is aggressive steroids and chemotherapy, and that's a difficult concept if you have an extremely sick individual that you're going to give them therapy that's classically going to make them more immunocompromised. So what is the test that you send to our lab, such as Cincinnati or ARUP or other places, telling you? So in the very simplistic diagram provided by Dr. Michael Jordan from our institution to me to use in this talk, the hallmark of your immune system is you have your target cell, which is what you want to get rid of, and you have your killer cell, which is either a natural killer or a cytotoxic T lymphocyte, and that is what is going to destroy this hyperinflamed, virus-infected, or hyperactivated cell. And the main components are perforin and granzyme B. And in a simplistic way, perforin is the key that punctures the cell membrane, which allows the granzyme, the bomb, which comes through the punctured hole to get into the target cell and make it go away. And so not surprisingly, the underpinnings of genetic predisposition to HLH are in defects in perforin or granzyme B. So to actually have cytotoxic killing, what has to happen? So in the resting state, your cell has perforin and granzyme B in a resting non-activated standpoint. First, you have to form your secretory granule in response to a stimulus. Then that granule has to be polarized, heading towards an immune synapse, using microtubules to dock at the membrane. Then you have to prime the granule or light the fuse. The perforin has to puncture the cell membrane. And after the puncture, then the granzyme B is released into the target cell, which leads to destruction of the target cell. And so in this simplistic 6-step process, you can imagine that if there is a defect in one of these steps, then there's going to be a problem with cytotoxic killing. And so here's our genetic defects. If you can't form the secretory granule, such as in a patient with Chiari-Higashi who has a defect in LIST, they are not going to be able to make this granule. If you can't polarize with a defect in AP3, which is Hermansky-Pudlak type 2, or if you're unable to get your microtubules or leave your microtubules, such as Griscelli syndrome, a defect in RAB27. Monk 13.4 is you can't light the fuse. This is typically a hypomorphic mutation, meaning that, not unlike when you use a lighter, 1 out of 10 times or 2 out of 10 times you're able to light it, so you do have some cytotoxic killing, so you tend to present much later in life. If you can't fuse, so if you have a binding protein defect or a syntaxin defect, you can't form the granule and bind it to the infected cell. And then perforin, which is the final step that delivers the granule, but can't puncture it, and that's the most typical or the most severe in the early onset of HLH, and not surprisingly, because if you can do all this, but you're unable to puncture or deliver your granzyme B, you will not have any cytotoxic cell killing. So when you're looking to see if a patient has HLH, the screening, you want to look by flow cytometry for the expression of perforin and granzyme B. You want to assess for the efficacy or function of their natural killer cells, and there's 2 ways to do that. Classically, it's been a chromium release assay. Now we're moving on to a CD107A mobilization assay. And you also want to look at the biomarkers of potential disease activity, the soluble IL-2 receptor, also known as soluble CD25, ferritin. You can look at macrophage activation with the soluble CD163 expression. So here's a typical flow cytometry of a patient looking at their perforin and granzyme B expression. So you have your naive or unactivated CD8 cell and your naive non-activated NK cell. You get activation from a stimulus to become a cytotoxic T cell or a cytotoxic NK cell. So at the resting cell has a baseline expression of perforin. Upon stimulation, you have a marked increase in both the granzyme B expression and the perforin expression. If you had defects in either of those, there would be no change from your non-resting state. So with measuring NK cell function and looking at chromium release, in the lab we put the cells and stimulate them with radioactive chromium, which should travel and be taken up, put in the target cell. When the target cell lyses, the chromium is released, and we can measure that and determine if you have adequate NK cell function. This is one of the least favorite tests for our diagnostic lab to do, very sensitive, tends to have very wide false negative and false positive, and doesn't travel well. So we've tried to enthusiastically get away from doing NK cell function and are now doing CD107A. CD107A is a flow-based assay that everywhere there's a purple dot here is affected by CD107 or is measured by CD107A expression. And so we can now easily measure if you have CD107A expression. So if you are normal, at the resting you have very little. After stimulation, you have nice CD107A expression. Here's an example of an affected patient. You can see a very similar profile. Upon stimulation, their mean fluorescent index is less than 10% of the patient or of the normal control. And so we're now using this essentially to replace our natural killer cell function assay. So how do we treat HLH? For your goal from your induction therapy is to gain control of the damaging immune activation, treat the underlying infectious triggers, limit organ damage, and maintain remission until they go to bone marrow transplant if that's what they need. The definitive therapy is those patients who you believe have a significant risk of future recurrence by correcting the underlying immune defect with bone marrow transplant, with the note that not all patients will need bone marrow transplant. So the treatment of HLH, we use chemotherapy to get your hyperinflamed state down to a non-inflamed state. And during this period, we determine if you're at risk of recurrence, which would mean you need to go to bone marrow transplant, or is this just a one-time limited thing and you can just be cured with a course of chemotherapy. The shortcomings for chemotherapy is it doesn't work in every patient. Concern about transplant, it does work, but obviously there are toxicity with transplant. We'll talk about that. There's two approaches to how to do induction therapy. The main international approach is based on use of dexamethasone and etoposide in HLH 94 and now HLH 2004. Very large, long track record. This was a large international multi-year, multi-center study that has now been published and is very good. A second international approach with almost basically using the same drugs has the same results. It just has not been published. Current therapy of HLH94 is considered the standard of care, and that's what most people use at this time. The French do use a slightly different approach using horse serum or anti-thymocyte globulin and prednisone based. And really the summary and comparison, both of them have exactly the same success rates. I think the HLH94 therapy is easier to give and better tolerated, though the French approach doesn't use any chemotherapy but has a significantly higher infection rate. So your schematic is you start with very large doses of dexamethasone. We prefer dexamethasone because you get CNS penetration, starting out at 10 milligrams per meter squared per day for 2 weeks, then tapering. You use etoposide, which is very lytic to cytotoxic T cells and NK cells, with initially 4 doses in the first 2 weeks and then going less frequent. For those patients with CNS disease, they will need intrathecal therapy. And the initial induction is 8 weeks of therapy, and you should be in remission at the completion of your 8 weeks of therapy. The French use 5 days of horse serum or ATG, and similar doses. They prefer methylprednisone and some cyclosporin, but again, this is not favored in the United States because of a much higher viral infection rate. So you have decided the patient needs transplant and want to consider. So the initial approaches in the late 90s or late 80s and early 90s, as we were doing bone marrow transplant for HLH, our thought was these patients had close to a malignancy and needed the same approach as patients with cancer. And so we used our myeloablative preps, which would be similar to someone who had leukemia, AML, ALL. We quickly realized these patients had very high rates of toxicity with high rates of liver disease, veno-occlusive disease, lots of pneumonitis, lung problems, and an unacceptable death rate prior to day 100. Overall results published by multiple centers, including our center, showed essentially high 50s to 60% survival, which was no better than patients with ALL and actually in some ways inferior. So this led to a rethinking of what is the right approach in the early 2000s. And around that time, we actually borrowed from our adult bone marrow transplant colleagues who started doing reduced intensity conditionings so that they, mostly because they were looking for how to transplant patients in their 50s, 60s, and 70s. Or as I joked, all of my bone marrow transplant colleagues got to be older and realized our criteria that if you were over the age of 50, you couldn't get a bone marrow transplant, and the division chiefs started to realize they were all over 50 and they needed to figure out a way that they could still get a bone marrow transplant. That not all patients needed complete ablation of their marrow, but you might just need immune suppression. We started to develop techniques to do T-cell depletion. These patients seemed to have earlier immune reconstitution. They definitely had lower incidence of organ toxicity. This started to be pioneered in the non-malignant conditions or things like CLL or very slow-growing malignant conditions. And the adults published using an eltumazab, which is Campath, anti-CD52 monoclonal antibody, which destroys anything that expresses CD52, including monocytes, macrophages, and T cells, in conjunction with a fludarabine and melphalan. So really only one dose. Fludarabine is a very potent immunosuppressive, but if you just get fludarabine, you won't have mucositis, you won't lose your hair. So there's really now, instead of 9 days of chemotherapy, you get a single dose of melphalan as your only chemotherapy, and the rest of your transplant prep is a very potent immunosuppressive approach. So this was published in the early 2000s by several groups, including Shalini Shenoy in St. Louis and Dr. Cooper et al. At Great Ormond Street in London, and had some very encouraging results in preliminary small data set shown, and then this has led to more significant data sets. So the Great Ormond Street and their follow-up, and this is our data published by Rebecca Marsh not too long ago, that so just changing the preparative regimen changed our survival from essentially 50% up into the 90%. And here is the myeloablative approach from the late 90s, early 2000s, and here's our approach since about 2002 and on, showing over a 90% long-term survival for patients going for bone marrow transplant for HLH. So we did switch some of the complications in that this is an extremely potent immunosuppressive regimen, so you have a much higher rate of CMV, adenovirus, and other viral infections, but this does resolve within about 100 days after transplant. We also now realize that this is much more likely for these patients to develop mixed chimerism, where you have a mix of donor and host. And in a malignant patient, you do not want to retain any of your host hematopoiesis, but in HLH, you do not need 100% donor chimerism, and many of these patients will be fine with as little as 10 or 20% donor chimerism. So in our hands, most patients do develop mixed chimerisms, but that is okay for most patients. So what are the pitfalls that you want to think about when you're treating HLH? You need to diagnose it in a timely fashion. There is anxiety in all of us about starting very potent immunosuppressive therapy in the face of cytopenias and or infections. You want to always look for undiagnosed underlying infections that could be contributing or triggering the HLH. There's very significant early mortality, with greater than 20% of the patients in the initial trial dying in the first 30 to 60 days after they started therapy. This may be due to organ damage, and these patients tend to be very sick at the time of their diagnosis. Some patients do not respond, and then you're taking sick patients and giving them more myelosuppressive and chemotherapy, and so they may get a secondary infection. You typically are starting therapy for patients who have low blood counts, and we're giving them chemotherapy, so they typically get lower blood counts before they get better, and so this is one you have to often just progress through and treat despite their poor counts. Relapse is a concern, because it may take you several months to figure out if they have the genetic form. You have to have a very high index of suspicion that these patients could be relapsing as you're weaning their steroids. And most importantly is once you've identified it, you need to decide, is this primary or secondary, and do they need definitive therapy? So you want to maintain a high level of index of suspicion for HLH, screen early and often. Easiest screens are ferritin and a soluble IL-2 receptor. You want to follow up aggressively with potentially confirmatory testing. Maintain a high index of suspicion that if the patient meets the definition of HLH, they may have other and necessarily treatable disorders, other viruses, cultures, infections. And most importantly, if you think the HLH is the cause for their cytopenias or their liver dysfunction, you need to treat through that or they will not get better. Renal impairment is more difficult because of the need for dose reduction. You want to monitor response closely with both inflammatory markers and your routine clinical indices with ferritin, soluble IL-2 as your inflammatory markers, your CBC, LFTs, and fibrinogen. With your LFTs should be improving, your fibrinogen should be improving. Your CBC may be the one that lags the most because you're giving chemotherapy. Frequent assessment can help you to clarify your confusing situations and also decide if the patient is worsening ferritin and a worsening soluble IL-2 on therapy is a very poor prognostic factor. You should expect the patients will improve in the first 2 weeks of therapy. And some data that recently was published shows that if you still have a platelet count less than 40 and a ferritin greater than 2,000 at 2 weeks into therapy, this is a poor prognostic indicator, and you may want to consider whether to pursue salvage therapy if this is true. It can be difficult to diagnose CNS disease. You might obtain an MRI and an LP as early as possible in these patients, and consider if you think they have CNS disease to start treatment with intrathecal methotrexate as soon as possible. These patients typically need hospitalization, IV antibiotics, pneumocystis prophylaxis, may need IVIG. They should have antifungal therapy during their pulmonary neutropenia and aggressively monitor them for the development of viruses after the start of therapy. If you think the patient is going for transplant, please refer as early as possible to the appropriate transplant center and do HLA typing. These patients do best if they're in remission, but do not wait to get them in remission before calling us, as we are not able to produce a donor in 24 hours. It does take us a few days. So who do we think is likely to need transplant? For those patients that have a biallelic associated mutation, that is an easy one. Patients with positive family history, patients who have an incomplete response to therapy or have their disease recur. We have said that persistent convalescent decreased NK cell function might be an indication for transplant, but I think that is going away. And most importantly, those patients who are less than 2 years of age, that presentation almost always have a genetic predisposition. We're not able to confirm that in everybody. Our current genetic testing picks up about 60 to 65% of patients who have a genetic defect. We keep adding new genes. So we have to consider in a young patient that has HLH that they likely have a genetic predisposition. So this is available on our website about how to diagnose HLH and when to consider HLH with the different scenarios, and then the workup and the confirmatory immune studies and other things to consider, which leads, if you think the patient has HLH, we have a next generation sequencing panel that is looking for, and you can see in HLH 2004 or 2004 criteria, there was only 6 forms, and this is from about 6 months ago, and I need to download the new one because I think we've added another genetic test. And this can help you when you do your perforin, NK cell function, and CD107A. If things are normal or abnormal, it can lead you to what is likely cause, whether they're female or male, and additional screenings. And all that's available on our website, some contact information. And thank you for your attention.